Hello everyone, and welcome to this webinar about the most challenging cases in pediatric oncology, brought to you by the European Young SIOP Initiative. I am very pleased to welcome our young investigator who will be presenting today's case. Simona Zimova is a pediatric oncologist working at the Motel Hospital of Prague in Czech Republic. She is very enthusiastic about research work in hematology oncology and has spent 2 years around different departments trying to uniformize protocols used in pediatric oncology. So welcome, Simona. I'm also very pleased to welcome our expert for today, Dr. Calogero Virgone. Dr. Virgone is currently a consultant pediatric surgeon and assistant professor of the University of Padua in Italy. He has been involved in the activities of the Italian project on rare tumors in pediatric age since 2005, having participated on the drafting of the guidelines for neuroendocrine tumors of the appendix and adrenocortical tumors. He is an author and co-author of several abstracts and communications presented at national and international congresses. He is also a member of the experts since October 2019, and he has been elected member of the board. He actively participates to the actions of partner projects since its beginning, and is now responsible for supporting the main task of the project. Dr. Virgone, we are very honored to have you here today as an expert to comment on this case. So today's webinar is called Pseudopubertas praecox and the tumor rupture. Let me just remind the attendees, please write your questions in the question box and we will discuss them after the presentation. And now, Simona, please, the audience is yours.
Good evening, ladies and gentlemen. Here I would like to present a case of a boy that we met in our department in Prague around 1 year ago. So we can start with the presentation. There is the statement that we have no conflicts of interest to declare, both of us. And regarding the case, there was this 2-year-old boy who presented to his pediatrician with the catch-up growth during the 2nd year of his life when he moved to the percentile number 50 to the numbers over 97th percentile, and that made this pediatrician quite nervous, sent him to the endocrinologist, and further investigation was performed. Now we can move to the next slide. So when this boy came to our department, we observed this disturbance in the growth chart. We also observed, according to the parents, that there was the pubic hair growth lasting for 5 months, and they also observed the penis enlargement for 1 month. You can see how this genitalia looked like at the age of 2 years. But the testicles were still not enlarged, symmetrical, no signs of malignancy at that time. The parents also stated that the boy became irritable, aggressive, he had increased appetite, he started sweating during the night, during the day, and the endocrinologist that examined him, he found out that the bone age was of 5 years at that time. When we performed the laboratory evaluation of the hormone production, we found that the LDH was quite elevated to the value of 48, and there were elevated values of androgens, DHEAS, and testosterone, and also IGF-1 was slightly increased. However, there were normal values of other hypophysis hormones like TSH, LH, FSH, and the other hormones of the axis. So we can go further. And here's the first question for you regarding the originating site. of the tumor. So what is the most probable location based on the data that was presented right now? Could it be the central nervous system, adrenal gland, the testicles, or the thyroid gland? Yeah, well, so based on the presented data, the most probable site is the adrenal gland, which is 2/3 of the answers. And the fact is that the testicles were still symmetrical, and we would probably palpate a tumor if there was any, but it could cause a similar clinical appearance. So that was the adrenal gland, and we can move to the next slide to see what we found out. This is the MRI of the abdomen from the time of the diagnosis, and we found this quite huge tumor of the diameter 9 and 7 centimeters, with estimated tumor volume of over 500 milliliters. At the time, you can see the tumor pushing the kidney the downside, and it actually caused some painful symptoms to this boy. We can move further to the next slide. So we already had some suspicion regarding the tumor, and we indicated the boy for the left adrenalectomy, which unfortunately was complicated with the tumor rupture during the surgery, during the procedure of the extraction of the tumor, and the surgeons performed the lavage of the tumor bed mainly to try to avoid any residual tumor staying in the belly. When the histopathologist examined the tissue, they got a tumor of the size 8, 7, and 5 centimeters, but that was after the rupture. So actually, it's not really valuable. And the histopathological conclusion was adrenocortical carcinoma with the high number of mitosis, necrosis, and calcifications. They also described some angioinnovation. And we have next slide with the scoring according to the Virgone score. This is a scoring system that could be used in adrenocortical carcinoma, and you can base the prognosis of the patient on some signs that the histopathologist can describe. And if you find 3 or more of these signs, it shouldn't be considered benign, but indeterminate or malignant in its behavior. So we found actually at least 4 of these factors positive regarding the venous invasion, the presence of the necrosis, the number of the mitosis, and atypical mitotic figures. And actually, we don't have the weight of the tumor because it was the ruptured tumor, but it would probably be also over 400 grams. So we could expect that it would be a malignant tumor, and that's why we did what we did after that. And I have an additional question for you regarding the adrenocortical carcinoma. Which genetic syndrome could be associated with the pediatric adrenocortical carcinoma? Is it a familiar adenomatous polyposis or Oliver-Romaney syndrome, or neurofibromatosis, or Beckwith-Wiedemann syndrome, or Fanconi anemia? And multiple answers is possible in this question. So yeah, that's perfect. Actually, yeah, Liframani syndrome is the most important because it's positive in 50% or more children with adrenocortical carcinoma, but correct answers could be also the first one and the fourth one, familiar adenomatous polyposis and Beckwith-Wiedemann syndrome, since in some studies also the publishers described it could be associated with this tumor, but the most important is still TP53 mutation in adrenocortical carcinoma, so it should be examined in every child with this type of tumor. We can move to the next slide. And as we examined the germline DNA for the cancer predisposition in this patient, we actually didn't find any predisposition syndrome. The TP53 mutation was negative. When we performed the initial staging after this adrenalectomy, we did a PET MRI scan, and we didn't find any signs of residual disease. It was actually clear. The hormones normalized after the surgery to quite normal levels. You can see the levels of androgens and IGF-1 that were in normal range of the values after the surgery. So we can move to the next slide. In the time this patient came to our department, actually the only usable protocol was the one from the children's oncology group from the States that we used for the treatment. And when we proceeded with the staging, this patient was stage 3 because of the tumor spillage during the surgery. And on the next slide, we will see how the treatment was planned for this patient according to this protocol. So it was 8 cycles of the chemotherapy consisting of cisplatin, etoposide, and doxorubicin, according with mitotan, which is an adrenolytic drug destroying the cortex of the adrenal glands. So the idea is to destroy the cortex along with the tumor that could be still there. The plan was to give 2 cycles and then perform a first evaluation of the disease and also start with mitotan, which means you have to do the endocrinological follow-up because the patient needs to be substituted with the hydrocortisone because of the suppression of the adrenal cortex. We can move further. So, as I was talking about the evaluation, we performed an MRI after the second cycle, which revealed no clear sign of the tumor, no sign of significant recurrence, no sign of bulky tumor in the belly. But we also performed PET MRI scan after the third cycle because it wasn't possible earlier. And unfortunately, we found this lightening spot that you can see below the arrow in the bed of after the left adrenalectomy, which was very suspicious of local recurrence of the tumor. Let's go on the next slide. So this finding led us to ask the surgeons to resect this nodule. They were quite able to find it in the belly, and they also explored the abdominal cavity and revealed no other suspicious tissue. The histology of the nodule actually confirmed the progression or recurrence of the adrenocortical carcinoma in the site after the left adrenalectomy in the bed of the adrenal gland, and the size of this tissue was 10 millimeters. And you can again see the histology here, counting for mitosis and so on. The necrosis presenting. So this was evaluated as first progression on the treatment, and we were in a quite difficult situation in that time. So let's go further. And so this is the last question for all of you. Which treatment modality would you use if you were in this situation? So maybe you can use radiotherapy, second-line chemotherapy. You can just only use mitotan and follow up the patient, or you can use the immunotherapy. Yeah, so this is quite interesting question. But the answer from my point of view is not really clear, because there's no established second-line treatment. We were really not sure, because this is a very rare tumor of the childhood, and thus we decided to consult some experts. In that time, we consulted Carlos Rodriguez Galindo and Raul Ribeiro from St. Jude Children's Research Hospital. And actually the recommendation that we got were to keep the mitotan at first, and then stop the chemotherapy. Of course, that led to the progression, and start maybe the chemotherapy that was published in this article that you can see here in the study from Paulo Sperone, and we decided to start the second-line chemotherapy consisting of gemcitabine and capecitabine, and we were also advised to consider maybe immunotherapy in the future, probably not using the radiotherapy in this background, because there are no supportive data for its efficacy. So we can move further. We in this time of the progression, very early progression on the treatment, we also sent the tissue to the inform registry in the Germany that actually proved no strong druggable target. They confirmed the MYC gain with elevated expression of MYC protein, which could lead us to consider some inhibitors in the treatment, but as I mentioned, it was not a strong druggable target. Not evaluated like this, and other targets were borderline or low chance, low efficacy. So, but we have this information, and it's important that we have it, because we could use it in the future, but we didn't use it so far for the treatment. We can move further. So we started the second-line treatment in October 2020. The patient is actually in outpatient setting. Most of the time he's using the capecitabine orally, and 2 times in the 3-week cycle he got the gemcitabine intravenously, and he is still using the mitotan. He's followed up by the endocrinologist, substituted with hydrocortisone, and we regularly perform the follow-up with MRI and PET MRI scans, which were still clear until the October of this year. So he's been for 1 year in the remission. He's free of the disease. But in October of this year, we took the gemcitabine off the treatment, because he had repeated neutropenias, which we didn't consider efficacious for him. There are a few questions at this time that are stated on the next slide and that are pointed here to be consulted in the next section with Calogero. How long should the patient be kept on the second-line chemotherapy at this moment? So capecitabine and mitotan. What should we maybe do in case of progression, if it's localized or if it's metastatic? And on the last slide for now, I will summarize the patient. So it was a 2-year-old boy with adrenocortical carcinoma located in the left adrenal gland that was ruptured during the primary surgery. Unfortunately, we found a local relapse or progression after 3 cycles of chemotherapy, and we started a second-line treatment with capecitabine, gemcitabine, and continuing with mitotan, and he's free of the disease for 1 year and 1 month until now. The INFORM study actually revealed no strong druggable target. Maybe we could consider the MEK inhibition. So now I would like to finish my part and give the word to Calogero.
Thank you, Simona. Thank you for this very interesting and clear presentation. We still have no questions from the audience, so Dr. Virgone, I would like to ask you to comment on this case, please.
Yes, there are some things that need to be underlined on this case and all other critical tumors in general. First, for sure, is the surgical approach. As you have seen from the image Simona showed us, the tumor was quite big in a small child and with evident area of necrosis. The approach was correct in the sense that an open surgery has to be chosen in case there are high suspicions of malignancy. That it means high volume tumor, more than 200 cubic centimeter, for example, or larger area of necrosis, not clear margins at radiology, and suspicious nodes or metastatic involvement at the same time. And this is why, because this is because the risk of rupture, this tumor may sometimes present. Malignant adrenocortical tumors are very friable, especially when large area of necrosis are present. The other thing I want to underline that is that in case of rupture, an abdominal lavage, even if the washing is only local, should be avoided because there is a small risk but considerable of spreading tumor cells. Another thing that should be kept in mind is to perform a node sampling in any case, even if nodes are not evident at preoperative imaging or palpable during surgery. On the other hand, retroperitoneal lymphadenectomy has not been proven to be useful in children. On the contrary, in adults, there are some data that a retroperitoneal lymphadenectomy may improve outcome in localized adrenocortical carcinoma. There was a recent study performed by the COG that showed that there are no difference between the patient having a lymph node dissection and patient without a lymph node dissection. And tumor rupture is a key issue of these patients. It probably is the reason of the relapse, and you have to keep in mind that be avoided in all patients with adrenocortical tumors, even if they are benign looking at radiology. because tumor ruptures can lead to a fatal outcome in most cases. For what concerns therapy, another thing is to have the tumor evaluated by an expert pathologist, because it is important to have a prognostic score, and the prognostic score should be the Vineke score or the recently described 5-item score, because they are score built for the pediatric population, since the VICE score, the mostly body used in adult adrenocortical tumor, is not reliable in pediatric age. Lastly, I will say that for what concern how long to continue the current chemotherapy, there are no clear response answer for what concern capecitabine. But for mitotane, there are some suggestions to continue it for at least 2 years after the surgery, and some authors suggest also up to 3 years, in order to cover the period of maximum risk of relapse.
Okay, thank you. We have a question from the audience, from Adela Misove, questioning about what is the current experience in immunotherapy in these cases.
Low.
Have any experience on that?
I will say 0. The problem in relapsed patient or metastatic patient that there are no weapons to fight the tumor, and especially if they are not responding to first-line chemotherapy that is proven to be efficacious in adults. First-line chemotherapy is represented basically by cystatin, doxorubicin, and etoposide, and mitotane. So when a relapse occurs, or you have a stage 4 patients, you should always go looking for potential target, as from study that was done on these patients.
Okay, thank you so much. So I would like to ask Dr. Virgone again for your availability to be here, and all the attendings that were present during this presentation. And Simona, please, could you do the final remarks? And mute yourself, please, Simona.
Yeah. Thank you, Dr. Virgone, for the comments and notes. And this is like a summary regarding the adrenocortical carcinomas. It's one of the rarest childhood tumors. Its usual presentation in childhood originates from excess of androgens, which means precocious pseudopuberty in boys or virilization in girls, and it leads to the growth acceleration, which is quite different from adults with adrenocortical carcinoma who present with Cushing syndrome. Usually, the Li-Fraumeni syndrome is present in more than 50% of children with this type of tumor, and we should be aware of the fact that the testing for the druggable targets could be very useful and is important in these patients where non-established treatment in refractory relapsing tumors is. And the last slide is that there is some hope for future, because the guidelines are still very limited, but Dr. Virgone actually is part of the team of the expert partner group who created the first European guidelines for the treatment of this type of the tumor. But there is a lot of more work to be done regarding the second and subsequent lines of treatment, and we will see in the future.
Okay, thank you both again for your exciting participation, and thank you all for the attendings. I hope we will see you next month on the next seminar. Bye.
Thank you.
Thank you. Bye.